So go on, Travis. Yeah, I sorry I had to interrupt. Yeah, okay. All right. Yeah.
So the first aliquot, 63-year-old female presents with progressively worsening lower back pain. So that's our first aliquot.
All right, Ravi, what do you think?
Yeah. Thank you for giving me the opportunity. What I think is that evaluation of lower back pain. Interestingly, lower back pain can be like life-threatening conditions to self-limited conditions. So it's hard to like predict where we are landing. For life-threatening conditions, I want to rule out quad equina syndrome, like disc herniated, sciatica, any disc, nerve impingement. So back of my mind, I want to rule out any neurological emergencies. That's one. And then self-limited conditions range between like musculoskeletal, like osteoarthritis, arthritic conditions, like recommend physical therapy. It could be like trauma from occupational related, and it could be like spondylolysis. Those are my initial thoughts.
Awesome, Ravi. And I apologize if I get a coughing spell in advance for everyone. I'll do my best here. Yeah, I like right away that your brain is going to kind of what could some of the really serious things be causing this? You mentioned cauda equina. Ravi, often when we are thinking about back pain, we're told to think about what severe other symptoms should come up as warning signs for something really serious. Do you have a list of those severe red flag symptoms, as we call it, that you think about?
Yes, I do have those red flag syndromes. Yes, saddle anesthesia, urinary incontinence, radiculopathy, lower extremity weakness, inability to ambulate, weight loss, infection, like unintentional weight loss, fever, night sweats. So it could be infection etiology like epidural abscess.
Beautiful. Fantastic list, really comprehensive. Yes, we don't know that right now. All we know that this is progressively getting worse, but we'll really want to know if any of those serious red flags are there as we think about what's causing this. I like up front that you mentioned trauma being an important thing to get out of the history. That might expand our differential diagnosis in terms of what we're thinking of. And it might be a question that we have to very specifically ask. There could even be a sort of a minor minor trauma that even, for example, made the lower back a nidus of infection in some of the areas. So I think that'll be a very specific question that's helpful to know about. I think the only thing I'll add is kind of thinking about what is in or near the back in terms of the anatomy that can have a condition in it that can give someone pain. Ravi, you nicely mentioned certain anatomic areas that can have sources of inflammation and pain, including, you mentioned cauda equina, sort of the nerve roots, as well as the spinal cord itself, the vertebra, and the paraspinal muscles, I think, are also very important for that. I'd like to add two other anatomic sites that can cause back pain that are outside of the musculoskeletal structure of the back as we think of it. And that is some sorts of actually like intrathoracic in the chest cavity areas giving back pain. For example, we've heard before of severe aortic pathology like aneurysms or rupture causing back discomfort for people. Certainly any processes that are lower down in the posterior lung could cause back discomfort, such as an abscess or a lung cancer. So I'd like to add within the chest cavity as a source of back pain. And then finally, pathology that can pop up in the retroperitoneal area. So we'll have to think about worrying about perhaps the kidneys, the adrenals, the vessels back there. We've heard before about sort of an illness script of pancreatitis, including pain radiating to the back. There are processes that can just make the interstitial tissue in the retroperitoneal area inflamed or fibrosed. So I think as we hear the story, we'll really want to make sure we're thinking anatomically about our differential diagnosis in the musculoskeletal part of the back as we think of it, but also the chest cavity as well as the retroperitoneal space. But I'll turn it back over to you, Travis, and we'll get some more stories.
All great reflections, definitely. So try to give you this aliquot. I'll give you the history and some past medical history of the patient. So she's 63. She's coming into the emergency department. She notes she's having an exacerbation of her chronic lumbar pain over the last week that has been getting more severe over the last 2 days. She denies any acute trauma or insults or any recent events that she could relate to why her back pain is getting worse. She describes the pain as a constant and dull. It doesn't radiate. It's aggravated by mobilization and back flexion, most notably. She denies fevers. She denies any numbness, tingling, or weakness. There's no reported history of any urinary incontinence, fecal incontinence, or any sensory changes in her growing region. She has a past medical history of hypertension, diabetes, obesity, ESRD. She's been getting hemodialysis 3 times a week for the last year. And she has chronic back pain that's secondary to an accident that she had 5 years prior. She gets her dialysis through a prosthetic AV graft in the left arm. And she still makes urine. Her meds, she's on losartan, amlodipine, hydralazine, furosemide, gabapentin, and acetaminophen with codeine that she takes as needed. She doesn't smoke, drink alcohol, or use recreational drugs. And this is for Kushal. She hasn't traveled recently, doesn't have any pets, and doesn't have any unusual exposures or activities. So that's the end of the second aliquot.
Thanks, Travis. And hello, everybody. Sorry, I was sort of in transit still, but Raphael, what do you think about the new information we've gotten? Does it move the needle at all?
Well, I think the no urinary or fecal changes leads us far away from diseases such as pancreatitis. Usually you have some fecal changes. And I just want to add that we can still think about like some kidney changes, such as, I don't know, some infarct in the kidney, or this pain could be related to the accident, and add that we can think about ulcers, because it can lead to back pain. Usually I saw a case today that it was related with smoking and drinking, and it had back pain. It was progressively.
Thank you. Yeah, I think it would be really helpful to try to understand exactly where the pain is localized or where it's worst. If it's very clearly posterior and more in a kind of lumbosacral area, I think that would probably prioritize the musculoskeletal tissues a little bit more. Pathology of the kidney, of the retroperitoneum, oftentimes, it hurts a little bit higher in the kind of costovertebral areas or flanks. The detail about it worsening with flexion of the back also makes me worry a little bit more about the spine rather than the, peritoneal or retroperitoneal contents. And then what do you think, Raphael, about the history of end-stage kidney disease and hemodialysis? Does that put somebody at increased risk of any kind of pathologies that could present with back pain?
Like some chronic kidney disease, some kidney infection, or like
I think that's a good thought, depending on the mechanism of what the kidney injury or the chronic kidney disease is. So for example, if your chronic kidney disease is caused by polycystic kidney disease, those cysts themselves, part of the kidney, can get infected, they can bleed, they can hurt. So that type of CKD puts you at higher risk of actual pathologies within the kidneys, that are infectious or that could hurt. But usually, assuming that this patient's end-stage kidney disease is related to the diabetes and the hypertension and obesity, I don't know if necessarily a patient like that is at increased risk of, pyelonephritis or something like that. On the other hand, being a patient who receives dialysis and whose blood is essentially taken out of their body several times a week and circulated through, a machine and then put back into their body, these patients are at very high risk for bloodstream infections. And the level of risk is probably highest for patients who have a temporary intravenous dialysis catheter, then tunneled dialysis catheters, then AV fistulas and grafts are probably on the safer side, but there is still a dramatically increased risk of bloodstream infections compared to the general population. So with that, when you hear back pain, to me, I automatically worry most about, osteomyelitis and epidural abscess as the cause. And then for some of the other things you mentioned, like more superficial pathologies, ulcers, zoster, other things that could be seen, it's really important, obviously, to examine that area, palpate that area, and to sort of further pinpoint the localization of the disease. Why don't we get more information, Travis, and see what else we can learn from this patient?
Can I put one quick thought question to you guys out there, Ravi, Raphael, Zavin? Let's just, well, obviously she needs vitals and probably basic labs. But if, in the scenario where all of that is normal, with no red flags, I'm curious if you guys at this point in real life would pick some more diagnostic imaging for her, or would just treat her with symptom control and say, come back if it's worse. I bring this up because one of the themes of a lot of teaching in the sort of high value care choosing wisely campaign is when to get versus not to get imaging for back pain, particularly when it's acute on chronic like this. With the recommendation being if someone doesn't have any of those classic red flags that Ravi went through with us, it's usually okay to wait. But Raphael and Zavin had a great discussion about a risk factor for her with the end-stage renal disease, the kind of intravenous access she gets. So I'm just curious for you guys, if we see the vital, the exam and the labs are normal, And again, taking out of the fact this is a human DX case, right? It will probably evolve into something that's quite notable. Like in real life, would you get imaging for her? Would you kind of just make sure she feels better and have her come back? We can make it pretty quick. I'm just curious, Ravi, Raphael, Zavan, if you guys said imaging or no imaging in that scenario where everything else in her workup is normal.
I'm concerned about acute compression fracture. The compression, acute and chronic, that does warrant imaging and is progressively getting worse. The worsening part is concerning.
So you would favor imaging, Ravi. Okay, Raphael, what would your gut be if her exam vitals and labs are normal with just the story we have so far?
I would get some imaging, but I think in real life, like hospitals here, where I work, we don't get images. I don't think we would ask for images.
Thank you for bringing that up, Zavan. I'm curious what your real world perspective on what to do would be.
I think it really depends. As Ravi mentioned, I like that you sort of brought in, like, there's X-rays, which the threshold because they're quick and cheap, versus MRI. So there's sort of two tiers of, and they'll look for different things, right? With the X-ray, you're just kind of ruling out sort of over bony pathology as opposed to MRI, which is more thorough. But it really depends on sort of just how the vibes I got from the patient in terms of like how severe the pain is, how how different this is from her usual, I'm sure kind of fluctuating degree of pain if there's this degree of chronicity over 5 years. And the context, right? Somebody like walking into the ER at 2 a.m. is automatically sort of enriches for what I was referring to, which is just like how different this is from her normal, whether there was absolutely no kind of exacerbating trigger that is more mechanical or, overuse. And then when you say red flags, like there's a spectrum of thoroughness with which you could potentially look for red flags, right? Like some people are more able to kind of report constitutional symptoms versus others. Some people experience them more chronically, right? Kind of on and off and non-specifically, so that even if they say, yeah, I got a little chilly the other day, that may or may not stand out as much. And then in the lab work, like, are we just saying there's no white count, right? Or are we saying we also check the CRP and an ESR, and those two were completely normal? So I think there's sort of a degree of reassurance or non-reassurance that you could get as you look for the red flags. Or how about this? Like, sometimes you do a really thorough neurologic exam and you're like, okay, perfectly intact, right? Other times, the pain limits your ability to assess, strength, for example, or reflexes, and then you're not sure, you can't say with as much confidence that there's not a neurologic deficit. So I think it's always sort of a case-by-case decision. And in this case, I don't quite have enough information yet to be able to make that call.
Yeah, I'm with you guys completely. I think I just bring up the point because, right, there are guidelines on whether to image or not, but this is just a case to exemplify what Zavan said in general, right? It's every case is different, right? It depends on a lot of factors. So we'll see how this one unfolds. But I just wanted to bring that up because I think that would be an early decision in a lot of clinicians' mind, seeing her in clinic or in the ER for this. All right, Travis, what do you have for us?
Awesome, great reflections. Coming, working in the ER just by this history, not having the physical exam, the only red flag symptom for me is her past medical history and her, in her age. Otherwise, it seems pretty benign. She's got chronic back pain. So at this point, I would probably be hedging no, but we'll get some more information that might lead us to do that. So she heart rate was 63. Her respiratory rate was 18. Her blood pressure was 140/80. Her temperature was 98.4 Fahrenheit. And her O2 sat was 96%.
108.4, you said, right?
No, temp was 98.4. Sorry, 98.4.
Sorry. Yeah.
Wow, if it was 108, we've got our bright red
Yep,
flag
boom.
waving in our face.
Yep.
What was the SpO2s you said?
It was 96%.
Thank you. Yeah. All
In general, her appearance, she was lying in bed, looked fatigued, and was in mild distress. She had mild conjunctival pallor. Her cardiovascular exam was normal, no murmurs, rubs, or gallops, normal sinus rhythm. Her lungs were clear bilaterally, normal work of breathing. Her abdomen was obese, was non-tender to palpation. Musculoskeletal exam. She had pain that was reproducible midline at L1 and L2, as well as in the paravertebral muscles bilaterally at that same region. And the negative CVA tenderness, or otherwise known as a Giordano maneuver. I've never heard that one before. Usually people say Lloyd's punch or CVA tenderness, but apparently there's an Italian one called Giordano maneuver, which is, I guess, the same thing. Extremity exam, pulses were equal. There was mild, like 1+ bilateral lower extremity edema. The AV graft did not demonstrate any inflammatory stigmata or signs of complication. There was no bruit, and there was a thrill palpated. Skin exam, there was no bruising, petechiae, bleeding, no abnormal rashes on the back, and there was no jaundice. And neurologically, motor sensory exams were normal. And that's it for the physical exam. And then I'll give you some first aliquot of labs. White count was 10.7. It was neutrophil predominant. 86% neutrophils, no bands. Hemoglobin was 9.9. Platelets were 328. Basic chemistry panel, sodium was 136, potassium 4.1, chloride was 98, BUN was 48, creatinine was 3.8, calcium was 9. And glucose was 110. Urinalysis, the pH was 6. Specific gravity was 1.008. There were no casts. There was 28 red blood cells per high power field. There were greater than 100 WBCs per high power field. Urine protein was positive. The albumin creatinine ratio was 6. And the protein creatinine ratio was 10.79. And the first imaging that was done was a CT scan of the lumbar spine. Which showed some retropulsion of L1 and L2 posterior vertebral bodies in fragments with mild compression of the spinal canal. There is no obvious contrast enhancement in the paravertebral soft tissues. And that'll conclude this aliquot.
All right. Quite a bit here. Maybe Ravi, maybe you and I can tackle the exam and labs, and then let Raphael and Zavin kind of help us out with the imaging findings on top of that.
Yes, that sounds great. Vital signs are reassuring. No temperature, no tachycardia, blood pressure within normal range, saturating well. On exam, she appears fatigue and mild distress. It's kind of concerning. On the HENT exam, she's mild pallor, but when I interrupt my interpretation of mild pallor was anemia. The hemoglobin is 9.9. The hemoglobin 9.9. I mean, that could be from end-stage renal disease, anemia of chronic disease, or it could be multiple myeloma. I had a thought about multiple myeloma given the end-stage renal disease, back pain, maybe osteolytic lesions. Just one thought I had. Next, everything appears normal within normal appears normal physical examination. I just want to point out a neurological exam, which is reassuring. Motor and sensory is normal, so that's a good point. So we can rule out quad equina syndrome. We can rule out sciatica. We can rule out disc herniations. In the MSK exam, pain is reproducible in midline L1 and L2, and the paravertebral muscles. That is suggesting to me of musculoskeletal pain, and there's no CVA. There's no CVA tenderness. But on the laboratory data, WBC count is, on the urinalysis, WBC count is greater than 100. That is suggesting to me a urinary tract infection. Laboratory data, her patient is suggesting inflammation. Her white count is slightly elevated. White count is 10.7, and neutrophils are 86. Putting together, but she doesn't have a temperature. Temperature is 98.4. She has back pain, leukocytosis. And the further information, the laboratory data, and the urine analysis, the pH is 6.1, and WBC count is greater than 100. To me, is suggesting a like cystitis or lower bladder infection. Thank you.
Thanks, Ravi. I think what you highlighted on the physical exam is spot on. What stands out to me that to kind of conclude our discussion of, would you get imaging on this lady? Depends how she looks, given her degree of discomfort and the degree of kind of focal tenderness on exam. I think absolutely in real life would move ahead with imaging. And specifically, I think I would do cross-sectional imaging, right? Sort of deciding on availability of CT versus MRI, but there's enough here in her discomfort as well as sort of pain on her exam. I'll make a point. It's great that her neuro exam is normal right now. But with even severe pathologies like spinal cord compression from a mass or epidural abscesses, the first symptom is pain. The neurologic findings actually come later in the course. So the lack of nervous system deficit.
Steph, you're
oh, can you hear me?
You're kind of freezing on and off.
Can you hear me now?
Yeah, we can hear you.
Was just making a point that with the pain being there, with the normal neuro exam, doesn't mean there can't be a process present that eventually would give her neurologic deficits, but we may just be seeing it earlier in the course. With a spinal cord compression, pain is the first symptom. All of the neurologic problems come later. And so really still having many of those sinister causes on the list of possibilities is important. I think with the leukocytosis also, I totally agree with you, Ravi. That's a concerning sign for an inflammatory trigger, yet another reason to get the cross-sectional imaging. And I'm surprised by the UA. I think the fact, you're picking up the hematuria, the pie area. Let me ask you this, Ravi. Does this kind of back pain she has kind of fit your illness script of bladder infection versus other types of urinary infections versus do we need to start making this a separate problem from the worsening back pain she has?
Given the history of end-stage renal disease on hemodialysis, best of my knowledge, they usually don't make any urine. And I would say that this has to be like a separate problem than back pain because the location of the tenderness is paravertebral muscle, no CVA tenderness. So it's not involving the kidneys. And she's not describing to us like dysuria or any, but this is in the context of end-stage renal disease patients who don't make that much urine. That is kind of tricky. I understand what you're trying to say. Should we like connect the back pain to cystitis? But usually like, cystitis would be like suprapubic pain, dysuria, or urinary frequency. But however, she doesn't make urine. It's hard to tell. I would say both. Yeah, I mean sometimes like, the cystitis can cause like muscle aches, like myalgia, fatigue. They can cause more systemic. She's 63. She already has back pain, which is chronic for her because of car accidents. Maybe it's just getting worse because of inflammation and inflammatory markers.
Yeah, Ravi, I'm with you completely. I would separate it out at this point. Not everyone who's on dialysis is anuric. And so the fact that she makes some urine is helpful, but you just made a key point. We have to tie this abnormal UA with hematuria, pyuria, proteinuria also with symptoms too, to sort of figure out, do we have a separate potential GU infection going on? Or is there something else? So I completely agree, getting more focused history on any urinary symptoms, but probably working this up as a separate problem and seeing where it overlaps with the back pain is really important. Both thinking about ultimately for the urinary symptom, what can cause inflammation in the GU system? Infection can, but there's a lot of other processes, including infections that'll have a negative urine culture or just no bacterial or infectious findings at all. So I think we'll kind of have to put that as its own issue at this point. Being mindful of time, Raphael, Zavin, thoughts on this CT result that we've got now on top of this?
Travis, can you clarify real quick?
Yeah.
Could you read again? I understood there to be a fracture with posterior vertebral body retropulsion, but did I understand that?
Yeah, so there is the CT scan showed some retropulsion of some of the vertebral body elements at L1 and L2. It didn't necessarily say, there was a fracture, but just, I guess the definition, there are some bony fragments that have disrupted from the vertebral body and are now going into the spinal canal.
Okay.
What the etiology is?
Right. So, okay. So let's assume that we understood this correctly, that they're L1 and L2 vertebral body fractures with with the fragments kind of squishing the spinal canal a little bit. Raphael, how do you think about that? Why did these bones break, do you think?
I'm a little concerned about an infection due to the increased white blood count and the urinary white blood count. I would definitely ask for a urine culture. And I don't know, I was just thinking about this retropulsion. What was it about? Like, so you said it was a fracture. But I'm a little concerned about some other diseases such as multiple myeloma, but calcium is normal. Like we don't know if it's normal. We have to correct with the albumin. But right now I'm a little concerned about some kind of secondary infection. You said about dialysis infections, and I think I don't think this is like some trauma. I think this is a secondary infection in my point of view.
Thanks. I totally agree with you. So yeah, it does seem like we have to look for a possible sort of cause of a pathologic fracture, right? So vertebral fractures are extremely common, especially in older persons, older women, postmenopausal, osteoporosis, etc. And they can be spontaneous. Sometimes there's a clear mechanical sort of trigger, lifting something heavy, for example, etc. But other times it just a weight that your lumbar spine bears all the time. Spontaneous vertebral fractures are even common in the thoracic, even more common in the thoracic spine. But given the risk profile that everyone has already discussed, we have to consider and rule out infection and cancer as a cause of sort of fractures that shouldn't have happened. So I think we can investigate that further with an MRI, and we should. However, I think this line of myeloma, to answer your question, a normal calcium isn't sensitive enough, isn't enough to rule out myeloma. So I think getting sort of serum protein studies, electrophoresis and light chains, and just getting a total protein albumin to look for that is really important. So that's all I have to add there, and we can get the next.
You got it. So from here, some hospital course. So the patient was admitted and ended up developing kind of worsening blood pressure elevations, as well as worsening lower extremity edema, as well as edema in the face, torso, and abdomen. From there, some additional labs were sent off. A Cianca was obtained and was normal. A C3 was obtained and was returned at 41, which is low. A C4 was 21 and normal. ANA was sent in negative. Rheumatoid factor was negative. HIV, HCV, HBV were negative. Urine culture was negative.
Okay.
And I have two final bits of information. I can, I'll give you one, and the other one I will leave to interpret. Okay, so an MRI was done, and it showed, in addition to the CT findings of the vertebral body elements that were, compressing into the spinal canal, causing some spinal stenosis and cauda equina compression, there was also a spinal cord collection of fluid material at the L1 to L3 level, compatible with an epidural abscess. And the blood culture returned positive. And I'll leave that for the final diagnosis to tie everything together.
Zavan and Raphael, do you want to kick things off this time, and then we'll add some final points?
Sounds good. What do you think, Raphael?
Now we have to look for the agents that can cause epidural abscess. The agents that I can think of is like tuberculosis. I know that brucella can cause some pain in the back. Staphylo, Crucial said Candida. I didn't know about that, but I think we have to look for the agents.
Very good. I love that you sort of thought of tuberculosis and brucellosis, very common in many parts of the world. And, they could sort of manifest with multifocal infection, where routine cultures may not necessarily grow the organism, right? So that would explain potentially involvement of the GU tract as well, with significant inflammation, as sort of shown by that pyuria, but not necessarily, a positive culture. Is my voice okay? Some people on my screen are freezing, but I don't know if it's actually me who's freezing.
I think it's you. We can hear you perfectly.
Okay. But y'all can hear me?
Yes.
Okay, thank you, Blake. Okay, but Raphael, you mentioned staph, and that Staphylococcus and Enterococcus are probably the most common, as well as strep species, and they can be gram-negative rods as well. But Staph aureus is the most common cause of bloodstream infections, as well as epidural abscess and osteomyelitis. And Staphylococcus also has a propensity to spread bacteremically, like hematogenously, to the GU tract and cause UTIs. You would expect the culture to grow it in the urine, unless the urine culture was obtained after an initial dose of antibiotics was administered, or for other reasons, the sensitivity is not 100%. So I think epidemiologically, I still suspect Staph aureus first, and that's kind of but the blood is growing something, and whatever's growing in the blood can probably be assumed to be the same organism in the epidural space. So that will inform our antibiotic therapy. The next sort of therapeutic question is just whether the epidural abscess also needs mechanical drainage based on both its size, the degree of fluidity, and the local kind of ability of neurosurgery to intervene in a way that'll be more benefit than harm.
Ravi, anything you want to add on before we hear the resolution?
Yes, I would like to add on patient dialysis use of graft. So patient has a prosthetic AV graft. So could that be a source of infection because she receives dialysis every other week, inoculation with the needles? I was thinking probably that is a source of infection, the prosthetic AV graft. And that maybe causes, she's not an IV drug user. The only thing we can think of graft in stationary disease. I'm not 100% sure. Maybe she had catheters in the past. That could cause entering of bacteria in her bloodstream, cause abscess.
Yes, Ravi, I think you're correct. I'm actually going to quote one of Zavin's favorite teaching points. Do you want to talk about IV DUs, multiple meanings, Zavin? Zavin's comments, often we think of IV drug use, but as you're saying, Ravi, it's IV dialysis use, right? It's this, obviously under much more ideally sterile conditions, but this is a risk factor we identified from the beginning. I'm with you guys completely. I think the culprit organisms are there. I'll just add, we've got this whole other syndrome developing too, right? The edema, this active urine sediment, the uncontrolled hypertension. It really looks like there is a glomerulonephritis picture developing on top of bacteremia, on top of a back abscess. And so I think ultimately we'll need to be looking at what's a unifying driver that could go for this. And I think we need to start worrying about endocarditis, which has, as its manifestations, of course, bacteremia, seeding of that bacteremia, but then it also causes several immune complex related phenomenons, including immune complex related glomerulonephritis, which could really explain some of the renal findings we have, including the isolated C3. But Travis, for time, let's turn it over in here. I'm very interested to hear. This case got really complex. Yeah, I'm glad we admitted her. I'm glad we got imaging, right? A lot going on here.
All right, perfect. So the blood cultures returned positive for staph, and the case's final diagnosis was Staphylococcus associated glomerulonephritis, secondary to a pyogenic spondylitis. patient underwent a surgical debridement and spinal fusion. The primary source of infection was thoroughly investigated, but echocardiograms showed no vegetations and neither found signs of complication in the prosthetic AV graft that you guys mentioned. Therefore, the spondylitis was interpreted as resulting from the seeding of Staph aureus in an anatomically distorted vertebrae in a patient with risk factors for bacteremia. Kidney biopsy was withheld due to convincing evidence of the diagnosis, given the overt clear evidence of the glomerulonephritis with nephrotic hematuria, glomerular hematuria, clinical signs of overflow with the edema, well-documented and concurrent staph infection of a usual site, along with hypocomplementemia. And as the case progressed, the hypocomplementemia and the urinary sediment regressed 6 weeks after starting antibiotics. And, just a little bit about the SAGN, or the Staphylococcus associated GN. It's the presentation kind of includes directly related manifestations of the infection site, as well as glomerulonephritis syndrome features. So the expected findings would be proteinuria. And it's hard to, this patient has end-stage renal disease. So that interpretation, I'm sure, kind of, it's like, hey, you expect to see that, right? So that, added a little bit. I think if somebody, Zamida came in and, you don't expect to see protein in his urine and there's some there, that makes it easier. But I think her having ESRD made it a lot more challenging. But that protein will worsen. And then the development of hematuria, 98% of people will have that. But you do not have to have red cell casts. Our patient did not. There is also leukocyturia, worsening glomerular filtration rate markers, and 50% of patients will have edema, and 30% of patients will have this fluctuating, increasing hypertension, as this patient did. And also there might be symptoms derived from consequences of both processes, like decompensation of CHF. And last clinical pearl to share that the author shared was that the diagnosis for vertebral osteomyelitis, it's the most sensitive exam. Blood cultures are positive in about 60% of cases, but ideally it should be confirmed by a biopsy. What I was always told, if you have someone that has osteomyelitis, vertebral body osteomyelitis, don't give them broad spectrum antibiotics right away, like we do in the ER. Everyone comes in, give them, they wait until you get cultures. I don't know if you guys are told the same thing. Is that kind of the same practice everywhere with you all? Besides the urinary abnormalities, there's an emphasis on hematuria and proteinuria, generally more intense, with a reported mean excretion of 3 grams per day. And some additional lab findings that are supportive of the Staph aureus glomerulonephritis are hypocomplementemia, which is seen in about 80% of patients. You'll have a low C3 and a normal C4. That's the classic pattern, while a normal C3, despite possible, is unusual. There's a low titer positive C-ANCA, which we didn't have here, but that's present in 22 to 30% of cases. And the diagnosis of SAGN is established by compatible clinical and lab presentations and findings, and reinforced by the PATH findings, which could include a kidney biopsy if you needed to, in conjunction with a concurrent staph infection and regression of these things after the infection is gone. So those are the teaching points. You guys did an awesome job.
Thanks for sharing the case, Travis. I think for time, Franco made great teaching points. We'll maybe just skip kind of reviewing them verbally today and just have them on the saved file. And thank all of you guys for participating. Ravi, Raphael, pleasure as always. And have a great rest of the week, everyone. Take care.